Eyes on that? Yeah, it's not coming there.
So the next speaker will be Dr. Mohammed Abdul Nazar. He will be speaking on postoperative neurological dysfunction. Mr. Mohammed Abdul Nazar is a consultant anesthetist and pain physician and chief of medical services at Sri Chand Specialty Hospital, Kannur, Kerala. He is the past president of Indian Society of Anesthetists Kerala, Anesthesiologists Kerala chapter, and is also the past president Indian Society of Study of Pain Kerala chapter. And he is a present state working committee member IMA Kerala State, and he has a keen interest in regional anesthesia, and he has been a faculty for many state and national meetings. Over to you, sir.
Good morning, respected chairpersons. In the next coming 15 minutes, I'll be discussing a very new topic, the postoperative neurological dysfunction. This is a disease which we have started noticing only the last 15 years. And many of the researches are still going on at many centers. So there is less consensus regarding the diagnostic criteria and the treatment protocols. So I'll be just highlighting what all advancements that has taken over during the last 10 years, mainly based on the reference of the literature. So this postoperative cognitive dysfunction is a broad aspect. Even after we finalizing the name of the topic, this has been changed recently as a perioperative neurological dysfunction, because these changes very well start even after the trauma, before we initiate anesthesia or surgery. There are four main things which come under this. One is the postoperative cognitive dysfunction, which is mainly a change in the functional aspect of the central nervous system. And the second one is the postoperative delirium, where there are more consensus which shows that regarding the diagnosis, and it is identified that there are definite physiological changes in this disease entity. Another less common but more serious and difficult to diagnose aspect is the postoperative covert ischemic stroke. This is very important because the pertinent clinical findings may not be so evident. And it is due to some small strokes, some embolization that has occurred to the small vessels, which many times goes unnoticed. And we may always confuse with the diagnosis of POCD and POD in such cases. And a high index of suspicion should be there. And that situation we must order for an MRI investigations. Hemorrhagic shock. Of course, many times we are encountered a surge in the blood pressure during the operation time or in the postoperative pain, which is mainly the pathology for development of the stroke. And in many instances, it requires either surgical intervention or radiological intervention, which is the dictum. So coming to the postoperative cognitive dysfunction, the operative value is most of the time important, which we have difficult to identify in most of the cases due to the practical difficulties. And unlike the postoperative delirium, here there is no change in the consciousness level, there is no change in the orientation or the attention level. And it starts 72 hours later, may last for 7 days to 1 year. But in few cases, rare cases, it can persist for many years and limit the activity. But in general, it is taken as it's a reversible process. So as already said, this is basically a physiological function failure where there's a failure of the information processing activities. And unlike the postoperative delirium, there is no fluctuation in the level of the cognitive function. This is a very important aspect, and consciousness is unaffected. Cognition, we know it is the invisible activities, just like what we receive from the atmosphere, how we acquire this function to the body, and how we process and how we respond. This is the domain which is affected in postoperative cognitive dysfunction. The incidence is more common in geriatric populations, and most of the recent research studies shows that there is no difference between the regional and general, but isoflurane is attributed to a higher incidence of this problem, and it is less when we are using dexmedetomidine. The duration of the surgery, the intraoperative surgical problems of hypoxia and hypertension, all this has an increased incidence. So we have encountered in pediatric population, the patients become restless immediately after, which we call an emergence delirium, which is also a perioperative psychological dysfunction, but it settles soon. And postoperative delirium usually starts in the early phase in the postoperative ICU, and it will settle very early, whereas the POCD is something which persists for a longer time. These are the risk factors, and one thing to tell you that the POCD and POD has almost the same risk factors to precipitate the diseases. An important recent development that has occurred in the recent years that is regarding the pathophysiology, where it is evident that during the surgery, there are a lot of chemicals that has been liberated from the surgical site, and that is transported to the blood, and this will disrupt the blood-brain barrier, and there is migration of the cell across this blood-brain barrier, which produces the typical pathological changes. And the main act is on the hippocampus. There are other things that the depletion of the antioxidants because of the oxidative stress, and the role of the vagal system has also been evaluated in this. So this is basically what we said, the peripheral inflammation induced by the surgery. Does anesthesia has got a role in the postoperative cognitive dysfunction? It's doubtful, but recent research suggests that anesthesia triggers the change in the blood-brain barrier, but the basic pathological function is the tissue damage factor that is released because of the surgical stress. Because there has been many instances where a similar problem has been encountered even after surgery under local anesthesia. But the question comes, the surgical stress is always there, but POCD occurs only in few persons, especially in geriatric. But why it happens, it is something that has to be investigated further. This is the chemical cycles that produces blood-brain disruption, and this is the oxidative stress. And the role of vagal reflex arch, which has been investigated elaborately during the research, because this is some factor by which we can prevent it and we can manipulate. There are less consensus regarding the diagnosis. So there are a lot of investigating scales and tools that is available. But most of the thing is the second one, the Montreal Cognitive Assessment is accepted more. So this is mainly something which is of preventive aspect. The preoperative preparation that is starting well above. It's for elective case, you start it even before 7 days. You allow these geriatric people to have exercise. You control all the preoperative factors like anemia, electrolyte imbalance, optimize the cardiac and the neurological functions, and start cognitive training. Intraoperatively, any factor which produces an insult, like hypertension, hypoxia, all these are trigger factors. And research has shown that dexmedetomidine definitely has a promising effect in the management and prevention of this disease. There are a lot of drugs in the list, as many of you know, the anticholinergics, benzodiazepines, the metoclopramide, all this, and the narcotics, all this has been attributed in the etiological factors. Regarding the postoperative strategy, it's always better you have a good communication and team who deal this sort of problem, especially in those who has developed this POCD. All those patients, if possible, start an early mobilization, and you have adequate pain management, not in the form of narcotics, better other analgesics, and if possible, in the form of a regional technique. And second thing, very simple and subtle things which we often miss is you try to remove the Foley's catheter alone, avoid the bed sensors, remove the IV cannula, and as far as possible, you prevent a restraint. This is the test that is showing. Regarding the treatment, there is no definitive treatment, and most of the time we go for the supportive measures, but there are two promising effects that has come in the recent. One is targeting the inflammation and the blood-brain barrier, and out of which the pericoxib, the COX-2 inhibitors, is found to be useful in many of the clinical trials. Dexmedetomidine is also useful in the intraoperative strategies and the postoperative strategies, which is known to reduce the real incidence. Other drugs are still under trial only in animal models and has not been convinced in the human trials. These are the other drugs. Now coming to the postoperative delirium, this is a definite entity where there is a physiological change. Unlike the other thing, not the thinking process, but there is a confusion, disorientation, and emotional dysregulation and sleep disturbance. Why this is very important? This is something which makes the people to lose their independence, and they are more confined to the hospital and they are more dependent. This is especially important in countries where there is a community living of the geriatric population, very difficult to manage, and it's a great financial liability for the state. So it is more in the geriatric population, as we already told. Coming to the diagnostic criteria, unlike the POCD, this has a definite diagnostic criteria, the Confusion Assessment Management Scale, where this disease is acute, fluctuating with some lucid intervals in between. And there is a lack of attention, and there is a change in awareness of the surrounding. And some of the features it shares with the POCD, there is a disorganized thinking, some flowing of ideas, switching from subject to subject. And there is a varying degree of the alteration in the level of consciousness. If the first 1 and 2, and either 3 or 4 is present, that as per this CAM scale, it is diagnostic of postoperative delirium. The management, also there is a definite protocol, the hospital elder life program, which is mostly accepted in many of the places, where it is giving emphasis for the non-pharmacological management, and there are few drugs which has been tried. Just like we already told, you remove the intrusions and restraints, you promote sleep by non-pharmacological method, either by the counseling or providing a quiet atmosphere, involve the family wherever there is possible, you provide early mobilization, exercise, and visual and auditory aids. Another most promising thing is you provide a reorientation, where you bring back the person to know the date, the time, where he is having, what is his problem, what is his recent interest. All this should be recollected and promoted to recall, then it has found to be a better effect. And you give a nutrition and temperatures and prevent hypothermia. The pharmacological measures, only one drug that is very helpful, especially when you get an agitative phase, that is the haloperidol. Though the FDA recommends not to use this drug intravenously, but in the practical sense found that haloperidol 0.5 to 1 milligram slow IV is the best drug when there is a agitation of the postoperative delirium. It can be combined with lorazepam or betadesert, but repeat administration of haloperidol is found to have a very prolonged sedation up to 3 days. Other drugs is just under trial. Benzodiazepine is not commonly used as contradictory to our usual notion, but it is the drug of choice when you get a confusion state in alcohol withdrawal and withdrawal of the sedatives. So this is mainly the differentiating feature, which we already told. Delirium is faster onset, fluctuating. There is change in consciousness. These factors are not there, and it tends to be more chronic. There are a lot of trials under different bodies. One is in the United States Library of Medicine, where they have conducted studies in rodents, and some of the monkeys, and this they are trying to translate into the human beings, and it is still under evaluation. The European Clinical Trial Register and Australian and New Zealand Trial Register. It is already has consensus that too deep anesthesia and too light anesthesia is a provocative factor for perioperative neurological dysfunction. So the role of EEG to maintain this. BIS is also helpful, has been evaluated, and there are many supportive evidences. Intraoperative pulse oximeter has got a limited role, but intraoperative cerebral oximetry is, if possible, is found to have a better prognostic value in the development of this neurological dysfunction. As in Alzheimer's disease, there are a few cases where there are genetic factors of E4 is associated with the higher incidence, but that is still under evaluation. As we already told, dexmedetomidine is a promising drug in the treatment and prevention. What we are looking for is the biomarkers for this, identifying these people as a routine or as regular, and out of which only one drug that has been accepted more widely is the neurospecific analysis. Other amyloid proteins, precursor proteins, and tau proteins and calcium regulation are only in the experimental animal stage. So conclusion, this is the great problem of geriatric population. Why? Because there is an increasing geriatric people who have been operated for more complicated surgeries, and the population number is increasing, and that produces a great financial burden to most of the things to care them and to treat them. And adopting and pre-operative evaluation and finding out the high-risk candidates and adopting preventive measures is found to be a very effective method for its prevention. And one word of caution, these are related to many of the serious neurological functions like stroke or some hemorrhagic diseases that has to be minded and should not be missed. And whenever there is warranted, that has to be evaluated. So thank you all for giving me opportunity to present this topic. Greetings from ISA Kerala. Thank you.
Thank you, sir.